ओके गाइस, तो अब हम बात करते हैं एफएमजी दिसंबर 2021 के रिकॉल क्वेश्चन के बारे में। सो स्टार्टिंग फर्स्ट विथ इन्वेस्टिगेशन ऑफ चॉइस फॉर पल्मोनरी एम्बोलिज्म। अब इसको समझो, मोस्ट ऑफ द पेशेंट विथ पल्मोनरी एम्बोलिज्म दे आर एसिम्प्टोमेटिक। व्हाई? बिकॉज इफ यू सी आइदर द एम्बुलस इज टू स्मॉल, या तो एम्बुलस काफ़ी छोटा होगा, और आई कैन से देयर इज एम्बुलस ओनली इन वन ऑफ द वेसल, बिकॉज लंग्स विल हैव डुअल ब्लड सप्लाई। तो अगर एक में एम्बुलस है तो पता नहीं चलता है। सो इफ आई टेल यू अप्रोच वाइज, तो आपको क्या क्या आपको टेस्ट कराने हैं। सो वी कैन डू डिफरेंट टाइप ऑफ टेस्टिंग। तो आप एक एक्सरे करा सकते हो, बट अगेन एक्सरे विल बी नेगेटिव इन मोस्ट केसेस। देन वी कैन गो विथ सीटी स्कैन। सो जब आप स्पायरल सीटी कराओगे या सीसीटी कराओगे, तो सीटी के अंदर जनरली यू विल सी सम सॉर्ट ऑफ फिलिंग डिफेक्ट, तो सीटी करा सकते हैं। Then some people will have some manifestation in the ECG. So हर मरीज के अंदर ECG में चेंजेस नहीं आते। So very few patient will have a peculiar pattern, इसको हम बोलते हैं S1Q3 T3 pattern. But again, this pattern is not seen in all the patient. But what else we can go? We can do scan, इसको हम बोलते हैं VQ scan. VQ scan means ventilation perfusion scan. So VQ scan आप करा सकते हो। But to confirm the best test, or I can say investigation of choice, this will be pulmonary artery angiography. So vessel में एम्बुलस से कहीं भी एम्बुलस तो आप क्या कराओगे? एंजियोग्राफी. So this is the investigation of choice and this is the answer for our question. So let's see the option now. अल्ट्रासाउंड कराने का कुछ फायदा नहीं होगा. सेम विथ डॉपलर चेस्ट. Maybe you can get some information if it is a pulmonary venous thrombosis, right? CCT आप करा सकते हो, आई एम नॉट डिनाइंग, बट इन्वेस्टिगेशन ऑफ चॉइस विल बी कंप्यूटराइज्ड टोमोग्राफिक पल्मोनरी एंजियोग्राफी. सो एंजियोग्राफी को ही शॉर्ट फॉर्म में लिख दिया CTP. सो दिस इज द आंसर फॉर क्वेश्चन नंबर 1. सिंपल. सो आई होप आई एम क्लियर. सो दीज आर द टेस्टिंग दैट वी कैन डू. मूविंग टू नेक्स्ट वन. So this is a bit tricky question, which you will see wrong in most of the textbook, and many students have marked this wrong in their exam as well. So patient underwent THR. THR का मतलब होता है total hip replacement. तो पेशेंट की सर्जरी हुई आफ्टर अ फ्रैक्चर ऑफ नेक ऑफ फीमर. फीमर का फ्रैक्चर था. देन ही वॉज इमोबलाइज फॉर 3 months. 3 महीने बेड रेस्ट पे था, इमोबलाइज. ही प्रेजेंट विथ ब्रेथलेसनेस. सो अंडरस्टैंड दिस थिंग. If you see a patient underwent any big bone surgery or big bone fracture surgery, if there is shortness of breath developing in that patient, and I can say in 24 to 48 hours, then that could be a case of fat embolism. लेकिन यहाँ पर कब हो रहा है? सर्जरी. दिस इज द थिंग विच इज, जिससे आप कंफ्यूज हो रहे हो कि बड़े बोन का फ्रैक्चर है, आंसर होगा फैट एम्बोलिज्म. फैट एम्बोलिज्म कुड बी द आंसर व्हेन इट कुड बी अकरिंग इन फ्यू डेज, in 1-2 days, like 48 hours के अंदर हो रही है. So now you can see main cause is like he is developing this because of prolonged immobilization, not because of hip surgery. So fat embolism is not answer. Coming to air embolism. Air embolism, if you see air embolism, this is seen in divers. ये जो गोताखोर होते हैं उनमें मिलती है. Generally, basically, it is a nitrogen embolism. Now, systemic embolism you can see like whenever we have some valvular or I can say septal heart defects. So it is a simple case of thromboembolism which is migrating from limbs because of prolonged immobilization. Is it clear? So hip surgery देख के सीधे आंसर फैट एम्बोलिज्म नहीं करना है. तो आंसर विल बी डी. अ चाइल्ड इज अनेमिक. अनेमिया दिया हुआ है बच्चे में. MCV is less than 80. So this is the hint. MCV is less than 80 means, तो हमारे पास डिफरेंशियल आ गया. इट कुड बी सिड्रोब्लास्टिक अनीमिया, आयरन डेफिशिएंसी अनीमिया, थैलेसीमिया, अनीमिया ऑफ क्रोनिक डिसीज एंड लेड पॉइजनिंग. सो दिस इज कॉल्ड शीतल. सिड्रोब्लास्टिक, आयरन डेफिशिएंसी, थैलेसीमिया, अनीमिया ऑफ क्रोनिक डिसीज, लेड पॉइजनिंग. अब मैं देखो यहाँ पर बच्चा दे रखा है, सेंसिटिव के मैंने चाइल्ड, तो चाइल्ड दे दिया है. सो आई कैन से क्रोनिक डिसीज इज रूल्ड आउट. क्लियर? ओके, अब देते हैं लेड पॉइजनिंग. बच्चे, छोटे बच्चे को लेड पॉइजनिंग नहीं होगी, सो दिस इज रूल्ड आउट. नाउ वी आर लेफ्ट विथ सिड्रोब्लास्टिक. इट कैन बी, जिन बच्चों में हो सकता है बिकॉज ऑफ ALA सिंथेस डिफेक्ट. आयरन डेफिशिएंसी भी हो सकती है, थैलेसीमिया भी हो सकता है. बट नाउ दे आर टेलिंग यू विथ प्रीवियस हिस्ट्री ऑफ मल्टीपल ब्लड ट्रांसफ्यूजन. सिंपल. अब देखो अगली हर एक लाइन में, इन एवरी लाइन यू विल गेट सम हिंट. सो दिस इज द ब्यूटी ऑफ स्टडिंग मेडिसिन. इफ यू लर्न कंसेप्चुअली, एवरी लाइन विल गिव यू हिंट. तो आपके क्वेश्चन के सही होने की प्रोबेबिलिटी बढ़ जाती है. अब पेशेंट को मल्टीपल ट्रांसफ्यूजन हुए हैं, सो आयरन डेफिशिएंसी में ट्रांसफ्यूजन आप कर सकते हो, बट अगेन व्हेन इट इज वेरी सीवियर. सिड्रोब्लास्टिक में इफ यू डू ट्रांसफ्यूजन, दिस कैन कॉज आयरन ओवरलोड स्टेट, बिकॉज यहाँ पर तो ऑलरेडी आयरन ज़्यादा होता है, सो सिड्रोब्लास्टिक इज रूल्ड आउट. अब हमारे पास दो बचे, आयरन डेफिशिएंसी और थैलेसीमिया, राइट. नाउ यू कैन सी मल्टीपल ब्लड ट्रांसफ्यूजन बट नो इंक्रीज इन हीमोग्लोबिन लेवल. अगर आयरन डेफिशिएंसी होता, आप पैक्ड आरबीसी देते, ब्लड देते, वो बढ़ जाता. सो देयर इज नो इम्प्रूवमेंट, इट मीन्स इट इज ऑल्सो नॉट आयरन डेफिशिएंसी, इट मीन्स इट इज सम हीमोग्लोबिन चेन डिफेक्ट. इसीलिए आप ब्लड दे रहे हो, तो वो ब्लड जैसे पेशेंट को चढ़ता है, उसके बाद कुछ हफ्ते बाद, कुछ महीने बाद, व्हेन दीज आरबीसीज लाइक ट्रांसफ्यूज आरबीसीज की लाइफ स्पैन इज अराउंड 60 डेज. सो जैसे वो खत्म हो जाती हैं, अगेन पेशेंट will have symptoms. So that is something chain defect. So chain defect means it is a case of thalassemia. अब thalassemia को diagnose करने के लिए क्या करोगे? Let's see option now. Direct Coombs test हम कराते हैं. This test, direct Coombs test, this is a test we use for AIHA. AIHA भी बच्चों में हो सकता है, but again it is not a chain problem here. AIHA में MCV normal होता है, normocytic anemia. It's type of hemolytic anemia. So it's not iron deficiency, तो सीरम आयरन नहीं कराना. Osmotic fragility test, this is a test we do for hereditary spherocytosis. Hereditary spherocytosis में भी MCV कैसा होता है? नॉर्मल होता है, because that is again normocytic anemia. तो कैसे कंफर्म करोगे? थैलेसीमिया. So remember, whenever we see chain defect, जितने भी chain defect होते हैं, that is be it थैलेसीमिया हो और सिकल सेल एनीमिया हो, तो chain defect में आपको क्या कराना है? Best test will be HPLC. HPLC ऑप्शन में नहीं है, so second best test will be hemoglobin electrophoresis. Hemoglobin electrophoresis. So answer for this question will be hemoglobin electrophoresis. For sickle cell anemia, for thalassemia, for chain defect, best test will be electrophoresis. Moving to next one. Unconjugated hyperbilirubinemia. So remember, unconjugated hyperbilirubinemia we can see in Gilbert syndrome and in Crigler-Nazar. Crigler-Nazar syndrome. इसके टाइप होते हैं टाइप 1, टाइप 2. So understand chronic pancreatitis. So with remaining enzymes being normal, बाकी सारे enzymes normal है. So let's see option one by one. अगर हेड ऑफ पैंक्रियास का कैंसर होगा तो बिलिरुबिन बढ़ सकता है. आंसर इज यस, इट मे इंक्रीज, बट एंजाइम्स भी बढ़ेंगे. इवन पैंक्रियाटिक एंजाइम्स विल बी एलिवेटेड. वाइल हेपेटाइटिस में AST LT डेफिनेटली विल इंक्रीज. Chronic pancreatitis, again here understand now, you can see it is a disease mainly where pancreatic enzymes will be affected, not bilirubin. So the answer simple, it is a case of Gilbert syndrome. There are two more syndrome, Dubin-Johnson and Rotor syndrome. उसमें कौन सा bilirubin बढ़ता है? उसमें conjugated बढ़ता है. Yeah? So answer is A. Now understand, rhinocerebral mucormycosis is associated with. So this is like a topic. उस time ये disease काफी trending थी. So this is like what are the risk factor for rhinocerebral mucormycosis? So first risk factor is it is commonly seen in diabetic patient. In uncontrolled diabetes means, for example, any person who is having DK or diabetic coma. Then it can occur in those who take systemic steroid, जिनको लंबे टाइम से स्टीरॉइड चल रहे हैं. तो systemic steroid means this will cause immunocompromisation. Means immunocompromised state. Immunocompromised state. So I can say immunocompromisation. It can be like graft recipient, जिनको किसी भी तरीके का ग्राफ्ट लगा हुआ है. तो ग्राफ्ट से पहले इम्यूनोमॉड्यूलेटर ड्रग चल रहे हैं. So now let's see the option. Now see, inhaled steroid is not a risk factor. Systemic steroid is a risk factor. Systemic means oral IV or IM. Antibodies अगर किसी को मोनोक्लोनल चल रही, that is a risk factor, but more common is pregnancy भी हो सकता है, but more common is DK. So I have seen around उस टाइम पे जब मैंने देखे थे म्यूकरमाइकोसिस के 8 से 10 पेशेंट, and trust me, all were diabetic. So this disease is very common in diabetes, especially in those who have uncontrolled diabetes. Very, very important. So most important triggering event here is DK. Okay, so it's a simple question. So you can notice like there is ipsilateral loss of proprioception and contralateral loss of pain and temperature. So this is a classical case. So again, syringomyelia may present. It is like a cavity in your spinal cord. So this will present with painless burn in hand. Wallenberg syndrome is a type of lateral medullary syndrome due to occlusion of your pica. So patient की presentation stroke जैसी होगी. Guillain-Barré syndrome will have polyradiculoneuropathy. So means ascending radiculoneuropathy. Neuropathy वाले feature रहेंगे. So it's a classical case. Repeat question बार बार पूछते हैं. Ipsilateral loss of proprioception, contralateral pain and temperature. It's a case of Brown-Sequard syndrome. Okay, 10 soldiers after marching for 40 kilometers, 40 किलोमीटर तक पैदल चले, in extremely warm 40-degree atmosphere, present with dehydration and profuse sweating. So probably they are developing some sort of heat stroke. Now you will say sir heat stroke में sweating absent होती है, हर जगह नहीं होती, कुछ heat stroke में sweating हो भी सकती है. Now what should be next? Then next, put feet in ice water bucket. अगर आप ice water bucket में डालोगे पैर, all of a sudden it can lead to muscle cramp and hypotension and patient can die. Wash limb with cold water. Do not use cold water. If you use cold water, again this can trigger more all of a sudden vasospasm हो सकता है. एक स्टेमेटिल नाम से इंजेक्शन आता है, स्टेमेटिल ब्रांड नेम है और जो ड्रग नेम दैट इज प्रोक्लोपेराजिन. तो ये भी हम दे सकते हैं, बट अगेन दिस इज बेसिकली अ ड्रग विच विल हैव आई कैन से एंटी वर्टिगो टाइप ऑफ एक्शन. सो दिस यू कैन गिव, बट अगेन ऐसी कोई कंप्लेंट नहीं. सो फर्स्ट थिंग इज व्हाट वी शुड डू इज पुट वेट क्लॉथ इमर्स विथ नॉर्मल वाटर एंड पुट ऑन फैन. आपको नॉर्मल पानी से गीला कपड़ा लगाना है और पंखा चालू कर देना है, तो वो अपने आप धीरे धीरे ठीक हो जाएगा. यू कैन नोटिस मल्टीपल पंच्ड आउट लीजन. और क्वेश्चन को पढ़ लेते हैं. सिम्टम ऑफ हाइपरकैल्सीमिया, अनीमिया, लोअर बैक एक मीन्स बोन इन्वॉल्वमेंट, और एक यहाँ पर नहीं दिया लेकिन मैं लिख देता हूँ, दैट इज रीनल इन्वॉल्वमेंट. कैल्सीमिया, रीनल इन्वॉल्वमेंट, अनीमिया, बोनी लाइटिक लीजन. इसको बोलते हैं क्रैब फीचर. क्रैब फीचर प्लस बायोप्सी सजेस्टिंग यू प्रेजेंस ऑफ क्लोनल प्लाज्मा सेल्स. सो दीज आर लाइटिक लीजन. इसको हम बोलते हैं पंच्ड आउट लीजन. दीज आर कॉल्ड पंच्ड आउट लीजन. सो इट इज अ क्लासिकल केस ऑफ मल्टीपल माइलोमा. सो याद रखना, क्रैब फीचर प्लस you can see clonal plasma cells which are more than generally 10% in bone marrow. This is how we diagnose multiple myeloma. So hyperparathyroidism no, multiple sclerosis में lytic lesion नहीं होते. Langerhans histiocytosis can have some changes in the skull but not this. Crab feature नहीं होंगे. So answer is multiple myeloma. Simple, easier. Elderly male with myeloma defining illness. Myeloma defining illness are same जो मैंने अभी आपको बताए थे. Crab, कैल्शियम इंक्रीज, हाइपरकैल्सीमिया, रीनल इन्वॉल्वमेंट, अनीमिया एंड बोनी लाइटिक लीजन. बोनी लाइटिक लीजन कहाँ पे हो सकता है? स्पाइन में और ब्रेन में. एंड लोअर बैक एक. सो लोअर बैक एक इसीलिए हो रहा है. व्हाट इज नेक्स्ट स्टेप इन मेकिंग डायग्नोसिस? सोमैटोस्टैटिन रिसेप्टर सेंटिग्राफी वी डोंट यूज फॉर मल्टीपल माइलोमा. एक पेट सीटी आप करा सकते हो. पेट सीटी वी कैन डू व्हेन वी वांट टू सी द प्रोग्रेशन ऑफ डिसीज कि ये कहाँ कहाँ फैला है. Bone scan is to measure the bone density in osteoporosis, not here. So next test is electrophoresis. So इसको एक बार समझते हैं. Serum protein electrophoresis, in short we call this as SPEP, S-P-E-P. So just I want to tell you a drawing. Look at the screen. So जैसे आप किसी पेशेंट की electrophoresis करोगे, you will see a first spike. आपको जो पहली स्पाइक मिलेगी, दिस स्पाइक इज ऑफ एल्बुमिन. ये स्पाइक किसकी आएगी? एल्बुमिन की. देन यू कैन सी नॉर्मल कुछ स्मॉल स्पाइक आएंगे. दीज आर फॉर डिफरेंट इम्यूनोग्लोबुलिन्स. लाइक इट कैन बी IgG, इट कैन बी IgG, IgMI, IgA. इन मल्टीपल माइलोमा व्हाट हैपन, यू कैन सी फर्स्ट स्पाइक. ये तो किसकी आई? एल्बुमिन की. देन यू कैन सी, तो पहली स्पाइक आई इसकी. तो लुक एट द स्क्रीन. फर्स्ट स्पाइक इज फॉर एल्बुमिन. देन IgG एरिया में यू कैन सी अनदर स्पाइक विच इज स्लाइटली शॉर्टर देन एल्बुमिन स्पाइक. सो ये जो स्पाइक आ रही है, दिस स्पाइक यू कैन सी, दिस स्पाइक इज इन IgG एरिया in most cases, and sometime you can see this spike in IgA area. सो ये वाली स्पाइक तो एल्बुमिन की है, एंड दिस सेकंड स्पाइक विच यू कैन सी हियर, दिस स्पाइक इज कॉल्ड एम स्पाइक. सो इसको हम बोलते हैं चर्च स्पायर पैटर्न. सो एम स्पाइक याद रखो, एम स्पाइक इज नॉट सीन इन IgM एरिया. IgG में होगा या IgA में होगा. So next test will be serum protein electrophoresis B. Breastfeeding is absolutely contraindicated. So question was like galactosemia, maternal CMV hepatitis C, herpes infection without a nipple involvement. ये पूरा ऑप्शन ऐसे था, without nipple involvement. So let us see क्या मिलेगा आपको. हर्पीस इन्फेक्शन में अगर निपल्स का इन्वॉल्वमेंट नहीं हो रहा तो आप ब्रेस्ट फीड करा सकते हो, नहीं करा सकते हो, देन वी कैन गो. सो इट इज नॉट कॉन्ट्राइंडिकेटेड. हेपेटाइटिस इज ऑलवेज क्रोनिक, सो इट इज नॉट कॉन्ट्राइंडिकेटेड. मैटरनल CMV में भी अगेन नॉट. सो गैलेक्टोसेमिया baby cannot digest milk, so that is an absolute contraindication for breastfeeding. So answer will be A, simple. Patient of COPD is on salmeterol. Salmeterol means it is patient taking LABA and still has no relief in dyspnea. What is the next drug? So isko samajhte hain. So what is the treatment in COPD? Understand, in COPD patient what we do, we start our treatment with any bronchodilator. Any bronchodilator means we can start with SABA or LABA. Suppose आपने start किया SABA, SABA से short acting beta agonist like salbutamol, terbutaline. SABA से improvement नहीं आया, then we go for LABA. LABA means this is salmeterol, जिसके नाम में मेट्रो आ रहा है. मेट्रो बड़ी लंबी होती है तो long acting LABA. So LABA से भी improvement जब नहीं आया, then third thing what we can add is anticholinergic. Anticholinergic like ipratropium, oxytropium. Suppose there is no improvement even with this, so then what we can add, we can try inhaled corticosteroid. Inhaled corticosteroid से भी improvement नहीं है, then we can use systemic steroid. Systemic steroid. So this is the flow chart which you have to remember. अब याद करो, याद रखो इसमें. What else we can add? So remember there are two more things which we can add on these patients. So these are add-on therapy. Like many guidelines, they recommend to add a tablet of azithromycin in COPD patient because in most cases patient is a former or current smoker. What else we have? A new drug that we can add, that is rofilumast. इसके अलावा आप ऐड कर सकते हो like drugs like which act on leukotrienes. So leukotrienes receptor antagonist. So we have montelukast, zafirlukast, pranlukast. So अब देखो, let's see the question. Salbutamol, जब पहले आपने लाबा चला दिया, right? Look at the screen. लाबा से improvement नहीं आया, तो salbutamol is SABA. It means you have already given this. सिस्टेमिक स्टेरॉइड आप दोगे, बाद में दोगे. रोफिलोमास्ट अगेन वी कैन, अगेन न्यू ड्रग है, कई जगह अभी भी यूज नहीं होता है. सो व्हाट इज द नेक्स्ट थिंग? नेक्स्ट थिंग इज टायोट्रोपियम. सो जस्ट रिमेंबर टू मोर MCQs लाइक फाउंडेशन ऑफ ट्रीटमेंट इन COPD पेशेंट इज ऑक्सीजन. एंड व्हाट हरिसन सेज, ऑक्सीजन के अलावा व्हाट इज फाउंडेशन ऑफ ट्रीटमेंट? टायोट्रोपियम. सो देयर आर मेनी पेशेंट who will improve only with these two drugs. कौन कौन से? ऑक्सीजन और टायोट्रोपियम. सो आंसर क्या होगा यहाँ पर? एंटीकोलिनर्जिक मीन्स टायोट्रोपियम. सिंपल. A child has skin infection. Skin infection हुआ, 2 weeks later developed cola color urine. Cola color urine. So cola color urine means hematuria. Now see FSGS and MCD, ये दोनों नेफ्रोटिक सिंड्रोम है. नेफ्रोटिक सिंड्रोम में प्रोटीनूरिया होता है, हेमाचूरिया नहीं होता. Now understand PSG and IG nephropathy. So they are telling you skin infection हुआ है and after this 2 weeks later patient is developing hematuria. So this is a classical case and color of hematuria is cola color. So it's a classical case of PSGN. So ये भी क्वेश्चन एक वन लाइनर आता है, कोला कलर यूरिन इज सीन इन PSGN. Okay, there's a question on spot diagnosis. So what is the spot diagnosis? So you can see, अगर आप देखोगे like a finger's size is reduced, so it's quite normal. हमारा टो सबसे बड़ा होता है, फिर बाकी उंगलियां छोटी होती चली जाती हैं. So what is the change here? You can see two fingers are fused here. So when two fingers are fused here, what we call? We call this syndactyly. Syndactyly. Phocomelia is a seagull limb defect, जो thalidomide के side effects होता है. Klippel-Feil syndrome, again a disease where you can see defect in your scapular area, neck और पीछे के back में affect करता है. Colorectally is like a shortening of fingers, which is like universal. So answer will be a syndactyly. You can see syndactyly means fusion of fingers. X-ray changes in COVID-19 patients are usually apical coin shadow आपको मिल सकती है very rarely. Consolidation, you can see pneumonia. Peripheral reticular opacity, you again rarely see. What is most common change? GGO. GGO means ground glass opacity. This is the common finding which we see in long COVID patient. Identify the image. So ये image based question आया था जो कई सारे बच्चे समझ नहीं पाए थे. Complaint of distended neck vein. Distended neck vein means JVP बढ़ा हुआ, hypotension, muffled earth sound. क्या है ये? It is backstride. So diagnosis in this case will be cardiac tamponade. So and you can see this is like a blood. This tamponade can have fluid, it can have blood also. So it's like a bloody cardiac tamponade. It's not MI, it's not heart failure, it's not effusion, right? Okay, many students confuse कि सर pericardial effusion और cardiac tamponade तो एक ही बात नहीं. Pericardial effusion is a slowly accumulation of fluid surrounding your heart. A rapid and massive accumulation of fluid is called tamponade. So ये जो changes आ रहे हैं, these changes what I have written is engorged neck veins, hypotension, muffled sound. So these are not seen in minimal effusion, right? Like अगर आप देखोगे hypothyroid के कई सारे patient में effusion होता है, लेकिन backstride उसमें नहीं मिलता. Is it clear? So backstride you will see whenever there is a massive effusion, and that massive effusion is called cardiac tamponade. Simple. A baby is having tetralogy of Fallot and thymic hypoplasia. What is the diagnosis? So understand these are all genetic syndromes. So if I say Klinefelter syndrome can present to you with MS, it can present to you with MR, patient can develop mitral valve prolapse, and ultimately there can be heart failure, MI, and there can be some problem in aorta. So aorta defect. So these are the defect in Klinefelter. Turner की अगर मैं बात करूं, so Turner syndrome patient they will have some cardiac defects. So most common will be bicuspid aortic valve. But in MCQs they ask is coarctation of aorta. Coming to Down syndrome, here patient will develop most common defect that is called endocardial cushion defect. मैंने short में लिख दिया ECD, endocardial cushion defect. But patient can also develop VSD, ASD. So these are the defect in Down syndrome. DiGeorge syndrome patient will have tetralogy of Fallot, right? एक और याद रखना, like कभी कभी पूछते हैं Noonan syndrome, ये भी क्वेश्चन एक बार पूछा हुआ. Noonan syndrome will have which cardiac defect? It is pulmonary stenosis. So these are the cardiac defect in different type of disease. So answer will be DiGeorge syndrome, and it is basically like thymic hypoplasia. There is I can say patient will also have some other manifestation like, इसको याद करने का तरीका होता है catch 22. Catch means there will be cardiac defect, abnormal face, T for thymic hypoplasia, C for cleft lip and palate, and H for hypocalcemia because parathyroid का भी development नहीं होगा. Basically it's third and fourth pharyngeal defect. And this disorder will occur at deletion in long arm of chromosome 22. So 22q minus. और पेशेंट के टी सेल्स भी ठीक से मैच्योर नहीं होंगे बिकॉज देयर इज हाइपोप्लेशिया ऑफ थाइमस. सो टी सेल्स मैच्योर नहीं होंगे तो इम्यूनिटी कमजोर होगी. सिंपल. फॉलोइंग डिफेक्ट इज ड्यू टू, नाउ अंडरस्टैंड अगेन. सो बेसिकली इट वाज एन इमेज ऑफ एनेंसेफेली. सो आपसे ये पूछा गया कि एनेंसेफेली किस चीज का डिफेक्ट है? फेलियर ऑफ क्लोजर ऑफ एंटीरियर न्यूरोपोर दैट विल रिजल्ट इन एनेंसेफेली. दिस इज द आंसर. पोस्टीरियर न्यूरोपोर का अगर डिफेक्ट होगा then we call this spina bifida. Total closure of neuropore then what we call this craniostasis and absence of cranial bone. अगर bone नहीं है इसको बोलते हैं acalvaria. acalvaria. So anencephaly की इमेज यहाँ से मिस होगी, तो anencephaly किसका डिफेक्ट है? एंटीरियर न्यूरोपोर का डिफेक्ट. आंसर विल बी ए. A 40-year-old man presents with dry cough. On examination, clubbing is there. Clubbing आ गई. Central cyanosis आ गया. Late inspiratory crackles. In restrictive pattern, बस देखो restrictive pattern means अब क्वेश्चन में मेंशन कर दिया. They are mentioning you it's a restrictive lung disease. So chronic bronchitis तो obstructive होती है. Ruled out, right? Spirometry detected FEV1 of 60%. What can be the diagnosis? क्या क्या हो सकता है? What can be the diagnosis? Now coming to bronchiectasis. Bronchiectasis will also have obstruction, and remember here patient will have bronchoria. Bronchoria means wet cough होगी patient को, dry cough नहीं होगी. यहाँ क्या है? Dry cough. Now bronchogenic carcinoma and pulmonary fibrosis. Now these are two options left. Dry cough है, clubbing है, दोनों में हो सकती है clubbing. Central cyanosis again दोनों में हो सकती है. Late inspiratory crackles. So this is the hint. If it is bronchogenic carcinoma, then you can see early, mid or late. Any type of crackles, you can see these also. Then spirometry is having restrictive pattern. So restrictive pattern you will see exclusively in pulmonary fibrosis. I know many students confuse this, but आपको सोचना है, धीरे धीरे करके एक एक करके रूल आउट करना है. Okay, simple question है. Fixed wide split S2. Simple question. Yes. Patient came with symptom of vomiting. He was taking NSAIDs for long duration. So here you can see some gas under diaphragm. Patient की NSAID लेने की history है. NSAID लेने की history है. So patient को peritonitis हो रही है. So patient is having peritonitis, perforation peritonitis. NSAID की history है. तो क्या हो सकता है? Gastric cancer? No. Small bowel obstruction कहीं से नहीं लग रहा. तो उसमें अगर होता भी तो you will see like mainly they will tell you like X-ray of abdomen picture, not chest X-ray. Pneumoperitoneum, no. So it is a peptic ulcer which is perforated. And NSAID की history है. So NSAID can cause peptic ulcer disease. Simple. Patient develop allergic reaction after bee sting. Bee sting, मधुमक्खी काट गई, एलर्जी हो गई. All allergy, food allergy, peanut allergy, drug allergy, perfume allergy, pollen allergy. These are IgE. सारी एलर्जी कौन सी होती है? IgE mediated means type 1 hypersensitive reaction. So type 1 and IgE mediated. So answer will be D. Snowstorm pattern. Sarcoidosis will not have this. Kohlwerker pneumoconiosis में black lung होगा. Asbestos you will have pleural thickening. Snowstorm pattern is seen in silicosis. Again easy question. ये थोड़ा सा ट्रिकी था. 45-year-old man with known case of emphysema. 20-year history of working in factory. Present with daily symptom of chest tightness. Again, मुझे भी हरिसन खोलनी पड़ गई थी इस क्वेश्चन के लिए. Even I was confused. So sometimes you can see paper काफ़ी tricky आ जाता है. So we know like emphysema के patient के अंदर. So there are some risk factors. So most important risk factor is smoking. Then it can be due to alpha-1 antitrypsin deficiency. Then it can be due to some pneumoconiosis. Pneumoconiosis means occupational lung disease. So Harrison में जो pneumoconiosis mention थी, that was Kohlwerker pneumoconiosis. अब वो सबसे पहले नंबर पे लिखी थी, but that is not given in the option. So generally we teach till here. अब now understand. पेपर में क्या आ गया? Textile, shipyard, glass, cardboard. So which factory workers are likely to have pneumoconiosis? So remember, Kohlwerker pneumoconiosis के अलावा even textile industry can also have a risk of emphysema. So cardboard ruled out, glass minus में silicosis होता है, shipyard ruled out. So answer will be textile industry. 60-year-old man with complaint of progressive pallor, पीलिया हो रहा है, chronic abdominal pain from 6 months. So age 60 है. Bone marrow biopsy shows band neutrophils with basophil 4%, myelocyte and metamyelocytes, mature blast 9%, leukocytosis, thrombocytosis. What is correct? Okay, so let me see this type of question. You can see myelocytes. So it's some sort of myeloid leukemia. So myeloid leukemia कौन सा हो सकता है? CML और AML, right? ट्रांसलोकेशन 814 इट इज सीन इन बुर्किट लिम्फोमा, और बुर्किट बच्चों में होता है, रूल्ड आउट। सो बेसिकली आपसे सिंपल पूछा है व्हाट इज द ट्रांसलोकेशन इन सीएमएल। तो सीएमएल में कौन सा होता है ट्रांसलोकेशन 922, 28 यू विल सी इन मेनी प्लेसेस, 1221 इसको बोलते हैं मिरर इमेज, ये एएलएल में मिलता है, इट इज सीन इन एक्यूट लिम्फोब्लास्टिक ल्यूकेमिया। सो दिस 922 is called Philadelphia chromosome and this is classically seen in CML. So it's a case of CML. A patient is having sudden exacerbation of breathlessness. ABG दिया हुआ है. So pH देखो, pH normal value is 7.35 to 7.45. So pH is decreased. PCO2 is 35 to 45. PCO2 is increased. दोनों की डायरेक्शन अपोजिट है, so it's a case of respiratory. और pH कम है तो it's a case of respiratory acidosis. They are asking you what is the next line of management. Soda bicarb you will give in metabolic acidosis, not respiratory. Ammonium chloride again you can give this in metabolic alkalosis, but again not needed क्योंकि symptomatic treatment ठीक हो जाता है. Fluid restriction से कुछ भी नहीं होगा, so basically respiratory acidosis will be corrected automatically with NPAP or BiPAP or CPAP support. So अपने आप इससे ठीक हो जाएगा. It will take some time. So answer will be C, oxygen support or NIPAP. A male patient came with complaint of pain in index finger. दर्द हो रहा है इसमें. He has positive smoking history and is known case of Raynaud phenomena. What is the diagnosis? So you can see gangrene बन रहा है fingers में. So it's a case of thromboangiitis obliterans, or what we call this as Buerger's disease. So it's the classical case of Buerger's disease. So deep vein thrombosis आपके लोअर लिम्ब में होती है, राइट? ये बर्जर की स्पेलिंग देखो, दिस बर्जर डिसीज इज IgA nephropathy, IgA nephropathy, and this basically it's a kidney disease, and I can say patient will have gross hematuria, nephritic syndrome है, तो सिर्फ किडनी में प्रॉब्लम होगी. एओर्टिक एनेरिज्म में ऐसा गैंग्रीन नहीं बनेगा. सो स्मोकिंग की हिस्ट्री है, मेल पेशेंट है, right? So classical finding associated with Raynaud phenomena, that is what we call this Buerger disease or thromboangiitis obliterans. Diuretic of choice in cerebral edema without hemorrhage. So understand, we have vasogenic edema, then we can have cytotoxic edema, and we can have interstitial edema. So these are different types of brain edema. Now understand, in vasogenic edema we can use steroid, and in these two types of edema we prefer to use mannitol. Now steroid to option में नहीं, they are asking you diuretic which we use in edema. So in cerebral edema we have only one option, the diuretic that we use is mannitol. Furosemide is loop diuretic, काफी strong होती है, so we don't use. Hydrochlorothiazide is thiazide. Acetazolamide sometimes we use in pseudotumor cerebri. So again, answer will be mannitol. So answer is mannitols. A 45-year-old male present to emergency room with HbA1c of 8%. Diabetic है. Hemiplegia. 8 hours prior to consult. 8 घंटे हो गए. Stroke पड़ा हुआ है. Patient is in stroke. BP is 198, 102, normal NCCT head. What is the next step in management? Okay, so understand, CT is normal. It doesn't rule out stroke because understand this thing. अब आप बोलोगे TIA क्यों नहीं है? TIA होता तो ठीक हो जाता, पेशेंट ठीक ही नहीं हो रहा है. So it is a stroke, but understand, in stroke, what we do, the treatment should be thrombolysis. But for thrombolysis, patient should come to you in less than 4.5 hours. इस पेशेंट को कितना टाइम हो गया? 8 घंटे. सो दैट थ्रोम्बोलाइसिस विंडो पीरियड हैज गॉन. सो जो 4.5 आवर्स का विंडो पीरियड था वो चला गया, राइट? सो आप थ्रोम्बोलाइसिस मींस TPA नहीं दोगे. एंटी हाइपरटेंसिव इन स्ट्रोक वी रेकमेंड. एंटी हाइपरटेंसिव कब चालू करने हैं आपको? व्हेन BP, यू कैन सी BP इज मोर देन 210, राइट, by 110. तो 210 के ऊपर BP जा रहा नहीं जा रहा. BP is 198, right? So antihypertensive you will not get. So patient को stroke हो गया, BP उसका you can see like blood pressure is lower, तो आपको और lower नहीं करना है. right? So what are the indication of doing thrombolysis? इसमें क्या करोगे आप, कुछ नहीं करोगे, you will just observe. So indication of doing thrombolysis means patient age is more than 18, then patient BP should be less than 185 by 110, and you can see patient should come in window period, then that window period should be less than 4.5 hours. So thrombolysis आप नहीं करोगे यहाँ पर, why? Because अभी भी उस रेंज में नहीं है और उसका टाइम भी निकल चुका है. So this is why the answer will be observation. A young male came with complaint of hypertension and profuse sweating, suggestive of pheochromocytoma. Pheochromocytoma का diagnosis बन गया. What is first investigation? So MRI is a radiological investigation of choice, लेकिन आपसे first पूछा, they're asking you first. The first test will be CT भी करा सकते हो. Radionuclear scan is MIBG scan that we use whenever it is a very small tumor, or extra-adrenal pheochromocytoma. Extra-adrenal pheochromocytoma को बोलते हैं paraganglioma. So first test क्या कराते हो? 24 hours urinary metanephrine level. That is a test for screening. So this is the test for screening or first test. So answer is A. Preferred treatment for unconscious middle-aged man with following ECG. So you can see ECG में आपको क्या दिख रहा है? You can see unidentifiable QRS. So it is a classical case of ventricular fibrillation. आपको पहचान में नहीं आ रहा कि ये P है कि QRS है. So ventricular fibrillation में आप ऑब्जर्व नहीं करोगे. कैरोटिड साइनस मसाज क्या करोगे? दिस वी डू इन PSVT. PSVT नहीं है, ICU में शिफ्ट करने का भी टाइम नहीं है. आप CPR स्टार्ट करो और पेशेंट को अर्जेंट डिफिब्रिलेटर दो. So treatment of choice for ventricular fibrillation will be defibrillator. Okay guys, so moving to next question. So we have a patient of TB found to be resistant for isoniazid, rifampicin, capreomycin and one of fluoroquinolone. It means levofloxacin, ciprofloxacin, moxifloxacin. So let's see. Monoresistant TB means whenever there is a resistance to either isoniazid or rifampicin. Any one, right? So any one. अगर किसी एक ड्रग का रेजिस्टेंट उसको बोलते हैं मोनोरेजिस्टेंट. इफ यू सी रेजिस्टेंट टू बोथ मींस आइसोनियाजाइड प्लस रिफाम्पिसिन, अगर दोनों का रेजिस्टेंट होगा इसको बोलते हैं MDR TB, मल्टी ड्रग रेजिस्टेंट TB. इफ यू सी रेजिस्टेंट टू आइसोनियाजाइड, रिफाम्पिसिन प्लस एनी वन ड्रग, इसके अलावा कोई एक और, दैट इज कॉल्ड पॉली रेजिस्टेंट. सो हियर यू कैन सी रेजिस्टेंट टू HR, capreomycin and any one of the fluoroquinolone. This is the definition, means whenever there is resistant to isoniazid, rifampicin, injectable drug like capreomycin, amikacin and fluoroquinolone. इसको हम बोलते क्या? इसको हम बोलते हैं XDR. And whenever there is a drug resistant to many drugs, even some all first line, all second line, and there is a resistant to even to some experimental drugs, उसको बोलते हैं TDR. TDR means total drug resistance. So this is the definition of XDR TB. Patient came in emergency room with difficulty in breathlessness, means patient की सांस फूल रही, shortness of breath. On lab examination, hypokalemia. Hypokalemia causes enlarged and prominent T waves on the ECG. Potassium levels are critically low. So it will be not enlarged, it will be flat T wave. So flat T wave आ रही है. Prominent की जगह it is a mistake here. So it is a flat T wave. Potassium levels are critically low. So this condition can lead to. So understand this. Hypokalemia है patient को. This is the first hint in the MCQ. And then you can see flat T wave. And ultimately it will lead to wide QRS. So this condition can precipitate a type of arrhythmia. And remember, a multifocal atrial cardia, here you will see more than I can say इसको MAT बोलते हैं, more than 3 different type of P wave. Atrial fibrillation again it can occur in patient with electrolyte imbalance, but unlikely direct narrow QRS. So most common electrolyte ECG changes that we see due to electrolyte imbalance like hypokalemia, which is a triggering event, is a development of torsades de pontis, twisting of point or torsades. So here what we see patient will have a wide QRS, and then you can see more than 3 different type of QRS. तो आंसर क्या होगा इसका? ए। 35-year-old मेल, यंग मेल, कंप्लेंट ऑफ वीकनेस आफ्टर लॉन्ग ऑफिस डे, लंबे ऑफिस दिन के बाद वीकनेस हो रही है. He has a lot of being called sleepy at workplace as his eyes appeared drop by the end of the day. Means what it is? ये क्या है? It is ptosis. So patient is having ptosis. Doctor expressed it as ptosis. आगे दिया हुआ है. But again देखो आगे दिया ना दिया हो आपको समझना. First you have to figure it out. Aggravated by end of the day. What is your first differential diagnosis? So understand this thing. Patient is having symptom, right? And if you do like electromyographic study, or I can say if you do nerve conduction study here in this patient, you will notice first impulse will be bigger, then shorter, then shorter, then shorter. It will be progressively decrease. Similarly, compare this with patient symptom. So patient is fine in the morning, so by the evening you can see he is getting more tired, more muscle fatigue. This type of pattern, इस pattern को हम बोलते हैं decremental response, and this response is noted कहाँ पे मिलेगा ये? In repetitive nerve stimulation. So repetitive nerve stimulation में आपको decremental response मिलेगा. What is the diagnosis in this case? Understand, it's a classical case of myasthenia gravis. Oculomotor crisis will affect only oculomotor nerve, बाकी मसल में weakness नहीं होगी. Myotonic dystrophy will have proximal muscle weakness, right? Ptosis हो सकती है, but again it will not have this evening deterioration of symptom. Lambert-Eaton is myasthenia का उल्टा होता है. इसमें क्या होगा? By evening you will see symptom will improve. So answer is myasthenia gravis. A chronic liver disease patient was present to OPD on performing ascitic tap. Neutrophil found to be 500. What should be the first step? So understand, when total WBCs in ascitic fluid, they are more than 500. And out of these total WBCs, if you see neutrophils, they are more than 250. Then this condition is what we call this as spontaneous bacterial peritonitis. इसको हम बोलते हैं spontaneous bacterial peritonitis. So understand, in this condition, the drug that we use, so drug of choice will be cefotaxime. If cefotaxime is not available, then alternative to this means जो ascitic fluid है वो infected हो रहा है. Alternative to this will be ceftriaxone. So what you will give to patient? Cefotaxime or ceftriaxone, right? Octreotide we give in a patient who is suffering from esophageal varices. जो portal hypertension में liver disease का patient can convert, this patient can have portal hypertension. As a result, he can develop esophageal varices. In that case, you can use octreotide, right, or terlipressin. Even we can use octreotide in hepatorenal syndrome. So इसको कहाँ use करते हैं? We use this in HRS and esophageal varices. Large fluid paracentesis means बड़ा मात्रा में आपको पानी निकालना है. We do this when there is a lot of fluid, but here the fluid is infected. Albumin you will give to patient अगर patient का albumin कम होगा तो, नहीं तो नहीं देना. Simple. So what we give? We give cefotaxime. So understand, they can ask you a future question कि ये patient को spontaneous bacterial peritonitis हो गया है. So in treatment we will give cefotaxime. So for 5 to 7 days we are using cefotaxime. This patient should not develop this complication again. उसको ये दोबारा नहीं होना चाहिए. तो इसके prophylaxis के लिए क्या दोगे? We will use norfloxacin. So drug of choice for treatment is cefotaxime. For prophylaxis is norfloxacin. Okay, now look at the ECG. ECG में अगर आप देखोगे, then first thing which I am noticing this ECG is you can see some changes in the ST elevation, right? So अगर आप देखोगे, so where you can see changes in the ECG? You can see changes in V4, right? You can see changes in थोड़ा सा मिट रहा है. That is like V2 here, this V2, this then you can see V3. So V2, V3, V4 में आपको changes मिल रहे हैं. So again 2, 3, 4 changes, then it's a case of you can see ST elevation in 2, 3, 4. तो कौन सा MI होगा? Anterior MI, right? Am I clear? Anterior MI. A patient, which of the following is least likely cause for low BP? Low BP का least likely cause पूछा है ना, patient showing high ICP. Okay, let's see the question. ICP means intracranial pressure is increased and blood pressure is decreased. So suppose let me say abdominal bleeding किसी को हुई. Bleeding means hemorrhagic blood loss. So इस पेशेंट का बीपी कम होगा ज़्यादा होगा? बीपी तो कम होगा, right? ICP बढ़ेगा? No. So ICP may be normal. I am assuming intracranial pressure will be normal. So it is not the answer, right? So here you will see low BP to hoga. Retroperitoneal hematoma. Again, this hematoma can also bleed. So here can be either a decreased BP or many times it can also be a normal BP. Splenic injury. Splenic injury means splenic laceration. Again, there is a chance of bleeding. So again, patient will develop decreased BP. And ICP may be normal. So ICP here will be normal. So they are asking you least likely cause. Right? ICP can be normal, it can be increased. Suppose it is like a multiple road traffic accident where multiple injury in the body, then there can be raised ICP. So ICP बढ़ सकता है. In subdural hematoma, here you will see patients having bleeding in the brain. So यहाँ पर क्या होगा? ICP बढ़ेगा, right? And even blood pressure will also increase. So this is a case where you will not see low BP, right? So बाकी में ICP can be normal or can be increased, but here you will see ICP is increased and blood pressure is also increased. So this is the least likely cause. Answer will be D. Which of the following is true for patient with cardiac tamponade? So understand, tall T wave इसको हम giant T wave भी बोलते हैं और prominent tall A wave or giant A wave or prominent A wave. So this you can see in many conditions, like you can see in tricuspid stenosis, you can see this in restrictive cardiomyopathy, in cardiac tamponade में मिल सकती है. So tall T wave is present. So मैं इसको रख सकता हूँ यहाँ. It can be the answer. It's a feature. It can be seen, right? Pulsus paradoxus always present. Pulsus paradoxus is present in approximately 70% of patients, not in all patients, right? हर patient के अंदर नहीं मिलता. What is pulsus paradoxus? It's fall in systolic blood pressure more than 10 mmHg during inspiration. So it's a feature of cardiac tamponade, but again हर मरीज के अंदर नहीं मिलेगा. Kussmaul sign always seen. So those 30% patients who will not have pulsus paradoxus, they will have Kussmaul sign. What is Kussmaul sign? Kussmaul sign is like normally JVP fall by 1 to 2 centimeter on deep inspiration. But if JVP fail to fall or it rather it increase on deep inspiration, that is called Kussmaul sign. JVP गिर नहीं रहा है. So Kussmaul sign again you will see approximately in 10 to 30% patient, not in all. Jugular vein column is visibly distended without pulsation. So if it is a cardiac tamponade, tall A wave you will see, so plus minus tall A wave or giant A wave in JVP. But it is more classically seen where in tricuspid stenosis, right? But this is something, jugular vein column is distended. Maybe it may have pulsation, may not. So that is what we call this muffled heart sound, or raised JVP and hypotension. These are three classical features that we see. So both A and D may be seen, but D is seen, which is something that is seen in almost all patients. So this is more correct. So I will say both D and A are correct, but D is a more correct statement. So answer will be D. So it's a classical thing that we see in cardiac tamponade. A patient had gastrectomy. So you can see, first you can see the tongue. So tongue is what you can notice here. Tongue is having prominent furrow. So sometimes we call this a geographical tongue. Gastrectomy हो गई. Stomach को निकाल दिया. Stomach produces intrinsic factor. Stomach will have parietal cells. These parietal cells will produce intrinsic factor. This intrinsic factor will take B12 to terminal ileum. आपने stomach निकाल दिया. You have removed the stomach. So no intrinsic factor means no B12 absorption, right? Anemia भी है. And you can see prominent furrows in the tongue. So it's a classical case of B12 deficiency. Vitamin C deficiency. Vitamin C deficiency will not have these findings. Anemia नहीं होता पहले तो. Biotin deficiency में नहीं होता. Niacin deficiency will cause 3D: diarrhea, dementia, dermatitis, and fourth will be death. So again, in तीनों में anemia नहीं होता. So that is simple thing where you can mark the answer correct. A young male came with complaint of retrosternal pain, indigestion, regurgitation, coughing, and burning sensation. So all classical feature. Retrosternal pain, छाती में दर्द, indigestion, regurgitation, burping भी हो रही है, coughing हो रही है, burning sensation, गला जल रहा है, or I can say heartburn. So is it MI? No. MI will not have indigestion, regurgitation. Reflux esophagus, reflux esophagitis होता है, reflux esophagus कुछ नहीं होता. It can be diversification. No, it's a classical case of GERD. So maybe like a patient could be a smoker or an alcoholic, or he have taken high fatty food meal. इसने मोमोज खा लिए थे ज़्यादा और गरम मिर्ची वाला खाना ज़्यादा खा लिया था, but it's the case of GERD. Okay, so now understand. Patient is complaining of worst headache of his life. So this is enough. Plus you can see the white spot here. So that is a classical case of subarachnoid hemorrhage. So worst headache of his life means ऐसे headache को हम बोलते हैं thunderclap headache. So it is classically seen. You can see bleeding and worst headache of his life. That is these are 2 points favoring of subarachnoid hemorrhage. Child came with rash. It's a question which is like a very frequently tested in FMGE exam. बार बार आता है. Rash on lower limbs and abdominal and joint pain with hematuria. Yellow fever. Yellow fever will not have hematuria. Unlikely you will see yellowness in the skin. Dengue. Dengue can have rash. Yes. Dengue में rash होती है. उस rash को बोलते हैं island of white and sea of red. Can dengue have abdominal and joint pain? Yes. Hematuria, again, it is unlikely in dengue, right? SLE, a child पूछा तो again neonatal SLE will present with complete heart block, not with this manifestation. So understand this. You can see this rash, the rash that we see in Henoch-Schönlein purpura. This is like a petechial rash, and sometimes they give you image-based question. So this rash is more in the buttocks, in the thighs, and patient will have multi other organ involvement. Like if GI tract is involved, then abdominal pain. Then joint pain, sometimes hematuria, because many cases are associated with IgA nephropathy. So it's the classical case for Henoch-Schönlein purpura. Person with travel history from Assam to Delhi and is positive for Plasmodium falciparum. Assam से दिल्ली है, malaria हो गया. Which drug you will give? So now remember what is the drug of choice for falciparum. So these are old regime, quinine, chloroquine. Right, then chloroquine. Now what we use artesunate combined therapy or ACT, right? So travel history से confused नहीं होना है. So for malaria, now what we use artesunate based therapy. In short, we call this ACT, artesunate combined therapy. X-ray of patient is given. You can see these multiple. These are white fluffy opacity. This white fluffy opacity, what we call them? We call them cannonball nodules. These are called cannonball nodules, and these cannonball nodules, where we see, these are seen whenever any cancer is going into lung, means these are seen in lung metastasis. Fungal pneumonia, no. It will present with aspergilloma like a fungal ball. Interstitial lung disease will have interstitial involvement. So it is metastasis, means lung metastasis. And remember, most common cancer that goes into lung, that will be your breast cancer. And if I say lung cancer, they usually metastasize to 2 important areas. One is your brain, second is your adrenal gland. So these are called cannonball appearance. Easy one. Patient came with a history of regurgitation, barium swallow. What we can see? Corkscrew appearance. Strictures will have a peculiar narrowing. Cancer will have rat tail appearance. Achalasia will have bird beak appearance. This corkscrew appearance, this is called corkscrew appearance, and this corkscrew appearance is classically seen in DES or diffuse esophageal spasm. Okay, now we need to match the sequence in 1, 2, 3, 4. So remember, start like this. All people enjoy Time magazine. All people enjoy Time magazine. So how to remember this? So we are discussing the different location of heart wall. So all this A stand, this is first one, this A stand for aortic wall. So you can see it is in second intercostal space on right side. Then we have this 2. So I am telling you the sequence. Then what we have pulmonary wall. People means, again you can see this is where, again in second intercostal space, but on left side. Then you can see Here we have an area. This area is called Erb's area. This area is called Erb's area. We also call this neo-aortic area. Erb's area or neo-aortic area, right? Then what we have? We have tricuspid valve and we have mitral valve. So this is the location which you have to remember. 1, 2, 3, 4. So how to remember this? All people enjoy Time magazine. ऐसे आपको याद करना है. So match the following. So one will be aortic. Then we have pulmonary. Erb's नहीं दिया हुआ, so Time magazine. So answer will be 1, 2, 3, 4 APTM, right? 1, 2, 3, 4 APTM means aortic, pulmonary, tricuspid, mitral. Simple. Okay, one more thing, like in here, in first intercostal space, here also I can find one more area. This area is called Gibson area. This is called Gibson area. And इस Gibson area में क्या मिलेगा? You will get murmurs of PDA, that is patent ductus arteriosus का जो murmur होता है उसको बोलते हैं machinery murmur. That you will get in first intercostal space. Simple. Moving to next one. A patient 70-year-old came to emergency department with complaint of chest pain. Emergency duty physician sent his blood for troponin. Troponin के लिए sample भेज दिया because he is suspecting MI. Old people भी old भी है तो. So now when I see this thing, first thing is I can see the changes ST elevation in lead 2, in lead 3. Then I can see this where in AVF. So lead 2, 3 AVF. So when you see ST elevation in lead 2, 3, so understand this entry wall MI will have V2, V3, V4 involvement. Lateral will have, come on, which one? V5, V6 involvement. For this we need like V6, V7, V8 other leads. So this is called inferior wall MI. 2, 3 AVF में अगर changes है, that is a case of inferior wall MI. Okay, now understand. So this was a question. A medical student was asked to make axis deviation and a deviation diagram of this patient, and this question mark in this area represents. So understand this thing. So again, it's a simple question. They are asking you what is the axis. So here you can notice from minus 30 to plus 90, this is your normal axis. This is normal axis. This is called left axis. And this area plus 90 to 180, it is called right axis. And this, the left out space, is called extreme axis deviation. Extreme axis. So ये आपसे पूछा था, this is right axis deviation. So answer for this question will be right axis deviation. Where you will see, you can see in RVH. So it is in when heart is in right side, there is hypertrophy of right side of heart. Here, right axis deviation. An 18-year-old female with recurrent respiratory infection ECG is given. Now let us see the ECG first. So if I see this ECG, I can notice QRS is narrow, right? Then you can see P wave hai, P, QRS, then T, right? P, QRS, T. QRS is narrow, but P wave are there. So P wave are there, so fibrillation में तो P wave होती नहीं, ruled out. And I cannot see sawtooth pattern here, so sawtooth pattern is not there, so flutter is ruled out, right? WPW, here you will see QRS, this is suppose P wave, then this is QRS like this, but if you see P wave, then QRS will be slurry. So look at me once again, P wave, normal QRS is like this, right? If you see P wave, then you can see QRS like this. So this slurry upstroke in initial portion of QRS, this is what we call this delta wave. So delta waves are not here. So यहाँ पे QRS कैसे normally जा रहा है, there is no slurry upstroke, so that WPW is ruled out. So here if you see, this is a classical case. You can see P wave है, QRS है, right? And if you see the distance is irregular, so it's a case of sinus arrhythmia. Irregular RR, so sinus arrhythmia. WPW will have delta waves. Tall T wave, wide QRS and prolonged PR. There you will see hyperkalemia. Hypo and hypernatremia, generally they will not have ECG changes initially. Hypokalemia will have U wave. Hypokalemia में क्या मिलते हैं? U wave or flat T wave. Hyper will have tall T wave, wide QRS, prolonged PR, and sometimes you will get this type of pattern we call as sine wave pattern. Moving to next one. A known case of sarcoidosis present with vomiting. Sarcoidosis का patient है, उल्टी हो गई. Calcium level is 12.5. So calcium level is more. Hypercalcemia is there. So patient is having hypercalcemia, which is least useful. So they are not asking you question on sarcoidosis. Actually, this is a question on electrolyte imbalance. So आपसे पूछा क्या जा रहा है? आपसे पूछा जा रहा है कि what is not used to treat hypercalcemia. But आपको लग क्या रहा है? Sarcoidosis का question है. No. So understand, patient is having hypercalcemia. So in hypercalcemia, what I will use? Treatment of hypercalcemia. So first treatment in hypercalcemia is I will give a lot of fluid. So I can give fluid, IV fluid. Calcium ज़्यादा है, पानी मिला दो. Add water, dilute this. So IV fluid means normal saline. ये तो देते हैं. This we use. Least useful they are asking. Second is more calcium. What we can do? I can use loop diuretic. Loop diuretic. Loop means loop will lose calcium. That is not given in the option. Third thing is what I can use. Understand this thing. Whenever patient is having hypercalcemia, more calcium, maybe he is having some sort of bone loss, osteoporosis. That bone loss you can prevent or you can treat by giving bisphosphonate. So you can use bisphosphonates. So once bone will stop losing their calcium, so blood में आएगा, that will not come into blood, right? So bisphosphonate do we use? Answer is yes. Suppose if there is no improvement with bisphosphonates, now suppose we have given bisphosphonates, but whatever calcium in the blood, you want to send this back into bone. आपको इसको वापस से bone में पहुंचाना है. For this what we give calcitonin. Calcitonin, what it will do? It will send calcium back into bone. And remember, if it is a hypercalcemia due to some malignancy, due to cancer like squamous cell carcinoma of lung or breast cancer, in that case, we can use steroid. Steroid means we can use dexamethasone, prednisolone. So glucocorticoid, these are steroid. Mineralocorticoids will have no role in hypercalcemia. देखो क्वेश्चन क्या लग रहा था sarcoidosis का, लेकिन क्वेश्चन है क्या ये? इलेक्ट्रोलाइट इम्बैलेंस का. So mineralocorticoid means aldosterone. Aldosterone will have no role. This is the treatment of hypercalcemia. Refractory hypokalemia is present in a patient. What is next investigation? So understand this. Sometimes what happens, this calcium loss is related. This is associated with magnesium loss. So sometimes you can see you are treating hypokalemia. आप KCl दिए जा रहे हो, you are giving port chlorKCl. There is no improvement coming. Then you will notice like this magnesium sometimes drag potassium along with this. So we need to check patient serum magnesium whenever there is refractory hypokalemia, right? So we don't need to check other things. We need to check serum magnesium. Okay, so here let's see this. A 65-year-old man present with excessive cold intolerance. ठंड लग रही है, hypertension, slow ankle jerk, right? TSH is 16, TSH बढ़ा हुआ है, normal value is up to 5, T3, T4 they are low. So diagnose I got my diagnosis. It's a case of primary hypothyroidism. Primary hypothyroidism, and most common cause for this condition is Hashimoto's thyroiditis. What is appropriate management? So understand, in primary hypothyroidism we have to give drug. So treatment will be levothyroxine. So we are using levothyroxine and the dose is 1 to 1.6 microgram per kg per day before breakfast, BBF. So आपको पेशेंट को बोलना है ये गोली खानी है 1 to 1.6 microgram per kg per day खाली पेट सुबह before breakfast. This is the standard dose that we use in practice. So again there are three types of recommendation. Understand this thing. So there are three guidelines, or actually there are two guidelines. Either you can start with this dose which I told you, 1 to 1.6 microgram per kg per day. For example, my weight is 80 kg, तो आप मुझे 80 माइक्रोग्राम की या 100 माइक्रोग्राम की टैबलेट दे दो. Is it clear? Second is start with low dose. Start with low dose and gradually increase. This is more safe. So आप मुझे like 50 माइक्रोग्राम से स्टार्ट करो या 75 से स्टार्ट करो and gradually change the dose. The second is recommended. The second is actually recommended in we start with very low dose in a person with some cardiac disease, old people, right, or any comorbidity. तो ऊपर देखो यहाँ पर एज क्या है 65. तो आपको क्या फॉलो करना पड़ेगा? लो डोज. सो लेट्स सी T3 and T4 टुगेदर. नो. Start levothyroxine at 100 microgram and do TFT after 3 months. This you can do when weight is mentioned. अब इसमें weight mention ही नहीं है, right? Weight is not mentioned ना. But again, in old people we don't use this regime. 100 microgram and do TFT next month. ये आप तब करते हैं जब weight mention होता है और young patient होता है. Then TFT we repeat initially 1 month, then later on every 3 to 6 months. So आपको क्या करना है? Load. Old people remember this is our dose which I am writing here. In old people we always start with 25 microgram and gradually increase. So ये low dose का मतलब क्या है? In old people with comorbidity we start with 25 microgram. Is it clear? And gradually increase. Normal healthy adult में 1 to 1.6 microgram. आप 1.6 छोड़ो, आप 1 याद रख लो, 1 microgram per kg. 6-year-old child has recurrent episodes of blinking fast and then staring continuously. इसको बोलते हैं vacant staring spell. These episodes last for 30 seconds with sudden termination. अब देखो, there are vacant staring spell, blinking fast, so he's not focusing in his classes, so that's why he's having poor performance in school. What is the diagnosis? So diagnose means it's the case of absent seizures. Absent seizures, whenever you do an EEG, you will find spike and wave pattern, right? 2 to 4 at spike and wave pattern or spike and dome pattern. So absent seizures, the drug of choice is ethosuximide. Sometimes it's not available, then we can use valproate, right? Midazolam we use where? Midazolam is used in status epilepticus. Phenytoin nowadays we very less use. Diazepam again, a benzodiazepine. So valproate is our second best drug in absent seizures after ethosuximide. What is correct about ABO and RH incompatibility? So what I know is from my pathology knowledge, it is a type 2 hypersensitivity. Type 2 hypersensitivity means, remember, a mnemonic acid. Acid means type 1 is anaphylactic, type 2 is cytotoxic, type 3 is immune complex, and type 4 is delayed. So antigen antibody mediated, immune complex, cell mediated, cytotoxic. So it is cytotoxic means type 2. ABO incompatibility is type 2, cytotoxic. Patient from Kota, Rajasthan, working in stone breaking industry, developed TB. So simple. स्टोन ब्रेकिंग इंडस्ट्री में काम कर रहा है, आप टीबी हो गया. सो दे आर आस्किंग यू विच न्यूमोकॉनियोसिस, कौन सी ऐसी ऑक्यूपेशनल लंग डिसीज है जो टीबी के चांस बढ़ा देती है. सो विच न्यूमोकॉनियोसिस इंक्रीज द रिस्क ऑफ टीबी? द आंसर इज सिलिकोसिस. इसको बोलते हैं सिलिको ट्यूबरकुलोसिस. एस्बेस्टोसिस विल इंक्रीज द रिस्क ऑफ कैंसर. एंथ्राकोसिस, दिस विल इंक्रीज द रिस्क ऑफ एम्फाइसीमा. एंड बेरिलियोसिस विल इंक्रीज द रिस्क ऑफ ग्रैनुलोमेटस इन्फ्लेमेशन. So silicosis, remember, it increases the risk of TB. Silicotuberculosis बोलते हैं इसको. Vegetarian, 1, 2, 3, 4, 5, 6, more than 6 segments of neutrophil. क्या बोलते हैं इसको? Hyper segmented neutrophil. Vegetarian diet, peripheral smear is having a hyper segmented neutrophil. Who is on high fiber, present with complaint of weakness and fatigue. Hemoglobin is low. So what is the diagnosis? Vitamin E deficiency में anemia नहीं होता, C में नहीं होता. B9, B12 both can cause. B9 and B12 both will have this finding, but vegetarian, you will see in vegetarian B12 deficiency. Simple. So answer will be A. Mr. X, a 45-year-old male, presented with complaint of weight loss. Patient को weight loss हो रहा है. Fatigue, pallor, hemoglobin is 7, means anemia is there. TLC is 3000. TLC भी कम हो रहा है. Platelet count 1 lakh. So what you can see here, you can notice pancytopenia. All 3 cell lines are decreased, pancytopenia. On physical examination, hepatosplenomegaly. Hepatosplenomegaly. So these are 2 things in my patient. Iron deficiency anemia में generally pancytopenia नहीं होता, hepatosplenomegaly तो होती नहीं. Anemia of coronary disease will not have pancytopenia. Now 2 options are left. Aplastic anemia is anemia due to decreased production. RBC का production ही नहीं हो रहा. So reticulocyte count is reduced. Why people develop hepatosplenomegaly? Whenever there is early death of RBCs, जब RBC की death होगी, we call this I can say intra or extravascular hemolysis. So there is extravascular hemolysis. That is why means there is hemolysis or other than blood vessels. Blood vessels के अलावा कहीं और means in reticuloendothelial system like liver, spleen, lymph node. So there is more extravascular hemolysis. Aplastic anemia में क्या होगा? Hepatosplenomegaly नहीं होगी. समझ में आया? Hepatosplenomegaly is given, it means there is some sort of hemolysis. Hemolysis where you will see in hemolytic anemia, and only one hemolytic anemia is given in the list, that is PNH, paroxysmal nocturnal hemoglobinuria. याद रखना aplastic anemia में spleen liver normal होगा. Clear? I know pancytopenia देख के everybody think it is aplastic anemia. 24-year-old female came to OPD with complaint of malar rash. She is positive for anti-Smith antibody. What is the diagnosis? So I don't think I need to explain this. Scleroderma will have anti-centromere in Crest syndrome, anti-topoisomerase where in systemic sclerosis. Sjogren syndrome will have anti-Rho, anti-La, hemolytic uremic syndrome. It is basically due to I can say some toxins like Shiga toxins or enterohemorrhagic E. coli. So answer is clear cut SLE. Easy one. बहुत simple है तो. Menkes syndrome is due to defect of copper, and remember it is ATP7A. ATP7B gene mutation is Wilson disease. Selenium deficiency याद रखना, sometime it can cause hypothyroidism, right? Hemochromatosis gene mutation. So ATP7A, I told you it is Menkes, 7B is Wilson. Ceruloplasmin is deficient in Wilson, so it is due to HFE gene related. Hemochromatosis due to HFE gene mutation. A patient taking platinum based compound means cisplatin like or cisplatin like drug is taking for chemotherapy. So they are asking drug used to prevent nausea and vomiting in these conditions. So understand, whenever we treat, we give chemotherapy to a patient, what we give injection of MSAT. MSAT means ondansetron. So for prophylaxically understand what we can use ondansetron, we can use steroid, we can use dexamethasone or prednisolone. In chemotherapy induced vomiting, if it is delayed, means if it is 48 hours after chemotherapy, sometime it is not responding with these two, then we need to add a drug called aprepitant. Aprepitant is substance P inhibitor, right? So domperidone not effective here, scopolamine not effective, promethazine not effective. Ondansetron नहीं दिया, लेकिन उसका cousin दे दिया है better drug, newer generation of ondansetron, palonosetron. So remember, ondansetron, granisetron, palonosetron, these can be used for chemotherapy induced vomiting. So actually these are the drugs which we use. Lucid interval means patient is I can say having symptom. So patient stroke ka, he is having symptom. Symptom means he is having arm weakness, एक तरफ का हाथ पैर काम नहीं कर रहा, unilateral arm weakness, or he is having speech impairment. All of a sudden you will see this patient become normal. So this is a period like where a patient who is having stroke, all the stroke symptom, all of a sudden this patient become normal. That period is called lucid interval, and there is a possibility after a few days or few hours he can die. तो उसको कभी कभी बोलते हैं talk and die syndrome. So lucid interval means ऐसा period where patient become normal. कहाँ मिलेगा आपको? This is seen in EDH, extradural hemorrhage. Patient present to emergency room with a diarrhea and altered sensorium. He also complained of impaired memory. What could be the likely diagnosis? Diarrhea, altered sensorium, impaired memory. Okay, can you tell me arbiflavinosis means it is due to like riboflavin deficiency, ariboflavinosis, sorry. So this is again, it will present with cutaneous manifestation or manifestation surrounding the mouth only. Wernicke's encephalopathy, it is due to thiamine deficiency. So impaired memory, you can see here, dementia hoga, but it will not cause diarrhea. Scurvy will cause gum bleeding, not this manifestation. So it is pellagra. Pellagra में क्या होगा? Diarrhea, dementia, and dermatitis, which is not given. So again, we have two things. So answer will be pellagra. Niacin deficiency. Polyuria with no presence of sugar. Sugar नहीं है. Ruled out. Polyuria है. SIADH. SIADH में क्या होगा? SIADH will have oliguria or anuria, decreased urine output. So answer is diabetes insipidus. But B. So this is about our discussion, which we have discussed all the questions which came in like 2021 December. I hope you enjoyed this. See you in the next video where I'll discuss some more recall questions. Take care. Bye bye.